Okay, and welcome to the Davies Use Case webinar being presented by the Center for Addiction and Mental Health on Discharge Medication Reconciliation. This is the Davies Award-winning use case for the value of health IT. My name is Arnold Simmons, and I'm the Manager of Quality and Patient Safety, and it's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and information and technology enable patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. Davies Award recognizes outstanding achievement of organizations from around the world who utilize health information and technology to improve patient outcomes and value. Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health information and technology-enabled care delivery. So it's my pleasure to welcome our speakers for today's webinar. First, we will have an overview of CAMH by Damian Janakovich, who's the Vice President of Information Management and Chief Information Officer and Chief Privacy Officer at the Center for Addiction and Mental Health. And then we will have the presentation on discharge medication reconciliation by Beth Sproul and Jane Patterson. Damian, Beth, and Jane, I will turn the presentation over to you, and you can begin when you're ready.
Hello, my name is Damian Janakovich. I'm the Vice President of Information Management, Chief Information Officer, and Chief Privacy Officer at Center for Addiction and Mental Health in Toronto, Canada. It is my pleasure to introduce our Davies Award-winning case studies. A few words about CAMH. The origins of CAMH can be traced to the Provincial Lunatic Asylum, which has been formed in 1848. And since then, CAMH's history has reflected the evolving societal and scientific view of mental illness and mental health. In fact, CAMH has often led the transformation. The history of modern CAMH starts in 1999 with the merger of 4 founding organizations, some of them with a clear focus on clinical care, others with a focus on research. Our transformation continues. As you can see on the slides here, we've been building beautiful modern facilities in the heart of Toronto and delivering modern set of services to our patients. But who are we now? We are the largest mental health and addictions hospital in Canada. We're fully affiliated with the University of Toronto. We do lots of research all the way from basic science to epidemiology, and we do consider ourselves to be a world leader in brain science. We have 3 main sites in Toronto and about 30 locations in Ontario. And we deliver a large number of services, including emergency departments, inpatient treatment, day treatment, and partial hospitalization models. Just in terms of some numbers, just to give you a scale of our operation, we see about 35,000 unique patients every year. Some of these patients are quite sick. As you can see, we see a large number of schizophrenia, spectrum, and other psychiatric disorders, as well as substance-related and addictive disorders. In terms of staff, we have more than 3,000 staff, and we educate the next generation of mental health professionals. Our research has been growing exponentially in terms of both output and the value of grants awarded. Our clinical programs have really 4 different areas: acute care, complex care and recovery, as well as child, youth, and emerging adult program. Of course, we also have a number of clinical services that support those major areas. Over the last 6 years or so, we've been on a real journey of transformation into a data-driven organization. That journey started off with a complete IT infrastructure refresh and optimization. At the same time, we have undertaken a lot of standardization work of our clinical processes, as well as administrative processes, including centralized intake, which has prepared us very well for a clinical information system transformation. About 4 years ago, we went live with a fully integrated clinical information system, which has replaced the previous a very hybrid model. We had a lot of paper-based processes, as well as a number of semi-integrated systems. We decided to go with a big bang approach and essentially ripped all of them out on one day and have gone live with an integrated system in the same day. One of the things that we've done really well is that at the same time as we were preparing for our clinical information system launch, we've spent a lot of time building our enterprise reporting as well as business intelligence infrastructure. Hence, very, very quickly after going live, we were able to produce data and show to our clinicians the value of the information they were entering. We continued on that journey. We've created a performance improvement team whose goal is simply to take the insights from the data and drive them into the units and change the performance of the units. We've continued to standardize through and invested heavily into integrated care pathways. And most recently, we launched Krembo Center for Informatics, which we'll touch on a bit later. Here's a high-level schematic of CAMH as a data-driven organization. As you can see, central to our organization is our clinical information system. That data from that clinical information system really feeds our enterprise reporting platform, which we call CAMH, which integrates a lot of other data sources. And this is really the source of data where our performance improvement team looks at and generates insights which can then be driven onto the units and works with our clinicians to drive those insights onto the units. As you will see from our case studies, there's been really a lot of really positive, incredible work that has happened through that interaction. We take the data from our CAMH platform, de-identify it, and move it to our neuroinformatics platform. Here, we join it and integrate it with brain imaging data, as well as genetics data and other omics data to create this really multi-dimensional longitudinal records of our patients. And just recently, we launched Krembo Center for Informatics, which really has a critical mass of computational scientists that use sophisticated techniques such as machine learning and artificial intelligence to derive the next set of insights from this longitudinal patient, multi-dimensional patient record to learn new things about the brain and how we can use that information to advance care through personalized medicine. Those insights are then brought back into our clinical information system to drive next set of performance improvement in care. We were lucky to receive a number of awards on our journey. We're particularly proud of our HIMSS Stage 7 designation, which we have achieved last year. So why the Davies Award? HIMSS frameworks have really guided our decisions around technology since the beginning of our transformation journey. What really resonates with us is the focus on achieving patient outcomes through technology. Hence, the Davies Award is a natural extension of the work we've been proceeding with over the last 6 years. I hope you enjoy our case studies.
My name is Beth Sproul. I'm a clinician scientist at the Center for Addiction and Mental Health and the Leslie Dent Faculty of Pharmacy at the University of Toronto in Toronto, Canada. I'm the chair of our Medication Reconciliation Committee at the Center for Addiction and Mental Health. This story is related to our work on discharge medication reconciliation. This story will first review the local problem, then the design and implementation of our solution, how health IT was used, and the value derived. We know that discharge is a difficult time for patients with mental health and addiction-related hospitalizations. There is a high risk of readmission. The figure on this slide shows the 30-day readmission rate for these patients in Ontario has remained relatively stable and unchanged at around 9% in the past decade. Research, both internationally and in Ontario, has demonstrated that there are a few critical factors that affect readmissions for patients with mental health and addiction-related hospitalizations. CAMH examined its own data and determined that the same factors were at play in cases where patients were readmitted. Experience surveys reflected that these same areas were of concern for them as well. In order to have a meaningful and coordinated approach to address this problem, CAMH initiated a multi-pronged discharge optimization project, of which improving medication-related communication through enhancing our medication reconciliation process at discharge was a key component. The medication focus of this story is based on the knowledge that medication reconciliation at discharge is considered best practice to reduce medication-related harms during transitions in care. Our medication reconciliation completion rates at discharge had not reached levels that we considered acceptable to serve this purpose. This was reinforced in feedback from our patients that our medication information was not always clear. This is important because we know that medication non-adherence is a major reason for readmission in patients with mental illnesses. In addition, transitions in care are risk periods for unintentional medication discrepancies. Ultimately, reducing avoidable readmissions improves patient treatment along with reducing system burden. Medications are a mainstay in the treatment of most mental health conditions. They're required long-term, and many patients are on a combination of both mental health and medical medications, creating a complicated clinical management picture. Developing a discharge medication plan with the patient and communicating this effectively to the ongoing care providers is key. In a mental health setting, our patients tend to have longer lengths of stay than in acute settings. This means that we have greater opportunity to coordinate our discharge planning. From this diagram, it can be seen that although discharge planning is conducted throughout the admission, once the patient is ready for discharge, there are a number of medication-related tasks that need to be completed. Our existing discharge planning process was disjointed, though. The interdisciplinary nature of these tasks involving physicians, pharmacists, nurses, and social workers, and the lack of coordination, resulted in the medication-related components being done concurrently rather than in the order needed to reliably generate accurate medication information on the patient discharge summary. Or they were completed after the discharge summary was given to the patient, or they were not being completed at all. The next few slides highlight some of these problems. This is an example of the original discharge summary with an emphasis on the medication section. Several features of the medication reconciliation function were not intuitive, and inaccurate information was displayed if the discharge medication reconciliation process was not completed correctly. In addition, the information was not displayed in a patient-friendly manner, the formatting was inconsistent, making it difficult to read, and the medication section was embedded within a very long document that also pulled in educational resources. At CAMH, medication reconciliation at discharge is completed by psychiatrists. This graph shows our completion rates for planned inpatient discharges from July 2015 to June 2016, reaching approximately 75%. These rates do not include patients in our emergency department who are not transferred to an inpatient unit. The objectives of this work were to streamline workflow processes to save clinician time and prevent errors. We took a multidisciplinary approach to the process in order to improve rates of discharge medication reconciliation and to be able to provide meaningful information about medication to patients upon discharge, and ultimately to improve continuity of care and decrease readmission rates. iCare is CAMH's clinical information system, which helped us achieve HIM Stage 7 in June of 2017. The options proposed to achieve our objectives were reviewed and selected by members of the Pharmacy and Therapeutics Medication Reconciliation Subcommittee and the members of the Discharge Optimization Project Working Group. These members included frontline clinicians and representatives from medical informatics, health information management, and IT education. The benefits of using iCare for our solution included the fact that CAMH staff and clinicians are already trained and familiar with the system due to everyday use. The reporting features were available through existing infrastructure. Communication and automated tasks exist within the hospital-wide clinical information system. Change management, build resources, and governance structures were already in place and could be leveraged. And standardized documentation practices could be facilitated through workflow and build. So to achieve our objectives, we implemented 3 key interventions. To help coordinate team members' activities when planning for discharge, the estimated discharge date entered in iCare is now displayed on the electronic whiteboards on each unit and was added to the information displayed on clinicians' patients' lists. This is particularly helpful for pharmacists since most of our pharmacists cover more than one patient unit and could more easily track the plans for discharge. We also completely revamped our patient discharge information summary. Another group in Toronto developed the concept of the Patient-Oriented Discharge Summary, or PODS. Through extensive consultation with patients and families, the PODS format was adapted for use in our mental health and addiction setting. We took this opportunity to ensure that the medication section was optimized. All information on the PODS is pulled from iCare, and it was rolled out across CAMH. Thirdly, we implemented a mechanism for psychiatrists to be alerted to complete medication reconciliation at discharge. CAMH has a very defined governance process, which incorporates end users for changes to the clinical information system. We will outline some of the parts utilized for the discharge project. This project involved primarily the Integrated Health Record Council, the Pharmacy and Therapeutics Committee, and its Medication Reconciliation Subcommittee. More details will be provided on the next slide. After approval, the changes were sent to the Clinical Change Advisory Board to facilitate the IT build. The Integrated Health Record Council granted initial approval for the creation of iCare builds for the interventions outlined on the previous slide. This group includes end-user membership. The Medication Reconciliation Subcommittee consists of subject matter experts and end users who are responsible for conducting deep reviews on our medication reconciliation processes, including iCare build recommendations to ensure accuracy and usability. The Pharmacy and Therapeutics Committee owns and approves the medication reconciliation policies with consultation and voting membership of several end-user psychiatrists and pharmacists. In addition, the broader discharge optimization project provided recommendation and approval for the components and functions of this project, including iCare build, with input from clinicians, end users, patients, physicians, pharmacists, families, and nurses. This figure shows our revised workflow. The orange boxes identify where we have utilized health information technology to improve processes. The estimated discharge date facilitates planning for discharge amongst the clinicians involved to ensure components are completed. An alert will appear if the psychiatrist initiates the patient discharge order before medication reconciliation at discharge is completed. Once discharge medication reconciliation is completed, pharmacists use the discharge medication plan that is pulled over into a working form to customize and enhance the information that is auto-populated into the patient-oriented discharge summary. The PODS is then printed out for the patient and used in the discharge medication educational sessions with patients. To further help with medication-related communication, we have also recently developed a community pharmacy medication summary that uses information pulled from the discharge medication reconciliation decisions. The form is reviewed by pharmacists and then sent via autofaxing to the patient's pharmacy with permission. These processes are all monitored with feedback to clinicians and managers to form a data accountability loop. This is a screenshot illustrating the data entry screen for the estimated discharge date. An assigned clinician uses iCare to populate the EDD. The inpatient units incorporate discussions surrounding estimated discharge dates within their team meetings. The populated estimated discharge date appears on the clinical electronic whiteboard, which is present in all of our inpatient units to facilitate the discharge planning. The lower image is a picture of an electronic whiteboard. The second one. So the populated estimated discharge date appears upon the clinical electronic whiteboard, which is present in all of our inpatient units to facilitate discharge planning. The lower image is a picture of an electronic whiteboard. The table above illustrates how the estimated discharge date is included in the information pulled over from iCare. Likewise, the populated estimated discharge date also appears on the pharmacist patient list to facilitate discharge planning. This is a screenshot example of how the list appears, with the estimated discharge date on the right side column. The revamped patient information summary in the form of a PODS document is shorter, simpler, and more accurate. The medication section appears at the top, which is shown in more detail on the next slide. In order to ensure accurate information is displayed on the PODS, there are 3 variations on the information that is displayed, which are contingent on the medication reconciliation activities at discharge. Option 1 is considered the gold standard. This detailed grid with customized information for the patient appears if both medication reconciliation at discharge was completed and the pharmacist has used the purposely designed working form to document additional relevant medication-related information for the patient, such as the reason for use or when the next dose is due. Option 2 provides an accurate list of all the patient's current medications and directions. This is displayed if medication reconciliation at discharge has been completed, yet the pharmacist was not able to complete the information for the more detailed grid. iCare functionality allows for the translation of medical terms into patient-friendly language. Option 3 simply displays the message, please follow up with your physician or pharmacist if medication at reconciliation at discharge was not able to be completed. This is to prevent wrong information from being displayed. These options were designed to reflect the clinical reality that at times the ideal workflow at discharge may not be possible. This slide shows a screenshot of the alert that is displayed if the psychiatrist initiates a discharge order before medication reconciliation is complete. The psychiatrist can then cancel the order, complete medication reconciliation, and then reinitiate the order. There is also an override option if deemed necessary by the psychiatrist with the reason documented.
Okay. My name is Jane Patterson, and I'm the Director of Interprofessional Practice at CAMH, and I've been very involved in the implementation and adoption by clinicians of our electronic health record. I'm going to talk about some of the benefits that we've realized as a result of our interventions targeting better discharge practices, particularly with medication reconciliation. So this first slide recaps our interventions. So just to repeat, the first intervention that we did was the discharge date on the electronic whiteboard, and this allowed the whole team to better coordinate the patient discharge planning. We know that there are many barriers to successful discharges for psychiatric patients, and it is very important that teams work together to try to prevent readmissions. We try to do everything possible to prevent relapse, and often relapses occur as a result of people stopping taking their medication. It's important that all professionals, despite having their areas of expertise, have conversations with patients regarding the importance of adhering to medication. The patient-oriented discharge was a way to structure those conversations and to impart information to patients in a patient-friendly kind of way. We had, like many projects at CAMH, we do involve patients in the design of the projects, and this project was no exception. We had patients involved in the design, and they were able to give us feedback on ways to communicate that would have the highest rates of success likelihood of people really understanding the importance and understanding what the medication did and how to actually take that. So the PODS was one of the major interventions that we used in this project. And then there was the Discharge MedRec alert for physicians, and this was fired if physicians had not completed the MedRec process. So this slide looks at our actual MedRec completion rates. So you can see that prior to the interventions of the estimated discharge date and the pods and the alert, we were hovering around 76, 79%. As soon as we did start to intervene, you can see that in Q2 of 2017, we started the estimated discharge date, and the MedRec completion rates started to go up. We're very happy to report that at this point now in Q2 in 2018, we are at 99.3% completion. So we're very proud of that success rate on the MedRec completion. Now, if you look at this next slide, looks at the 7-day readmission rate. And again, I'll just highlight that this does exclude patients from the emergency department. This only looks at planned discharges. So once we started to implement our interventions, the estimated discharge date, the pods, and the alert, we did see a reduction in the 7-day readmission rate. So we were encouraged by that, those outcomes. And then we went on to look at 30-day readmission rates. And if you look at that, we continue to see a downward trend. So at this point, right now, we are hovering at about, at 8%. So not as good as the 7-day readmission rate, but the trend is downward for sure. So this graph just displays this in a different way, and again with the 7-day readmission, with the 30-day readmission. So this slide is a bar graph representation of the 7-day readmission rate completion, and you can see for patients who do have a PODS and a MedRec, we see a 1.8% readmission rate, and patients without a PODS and MedRec have a 5.7% readmission rate. Now we look at the 30-day readmission rates, and again, the trend continues to be downward. Prior to the interventions, we had a 9.82% readmission rate for 30 days. Following the interventions, we're looking at an 8.5% readmission rate. This, again, is another bar graph representation. So on the left, you see patients with the PODS and the MedRec, and over 30 days, we're seeing a 7.4% readmission rate, and patients without PODS and MedRec are a 14.8% readmission rate. So we're now looking at our return on investment, and the Canadian Patient Safety Institute does have a formula looking at reconciliated discharges and the cost of adverse events. We applied that same formula here at CAMH, and what we saw was even when our rates were less than ideal, when they were 62.9%, we had a potential saving of about $7.5 million. But following the interventions, when we had our rates up to around 90%, we realized a savings of $9.2 million, with the difference being a 25.9% increase in savings as a result of these changes and rigor with our MedRec and discharge planning processes. So if we just summarize, again, there are many, many barriers for psychiatric patients to successfully leaving hospital, and we want to, as much as possible, prevent relapse and prevent readmission to hospital, because we do know that when people relapse, they lose ground functionally. So we need to do everything we can to adhere to best practices to keep our patients engaged in the recovery process, and also many times successful recovery does depend on adherence to medication. So we are seeing that with this change at CAMH, we have been able to reduce readmission rates for patients with this improved continuity of care. We do have very much to multidisciplinary and better coordinated approach to medication reconciliation, with people understanding their own roles and understanding the roles of other professionals, and also being able to intervene in a more organized and collaborative way. The best practice guidelines are out there for the discharge process, and we needed to ensure that we were adhering to them. And so that's what we have essentially done. And also ensuring that patients receive accurate medication information on discharge. So this means talking to people in a simple language way about why medication is important, understanding their experience of side effects of the medication, understanding some of the barriers to why they may not be able to adhere to the medication, and really putting in environmental supports to ensure that there is the best potential for adherence, and also ongoing follow-up so that they can discuss any sort of side effects that they are having. With the pods, it's very important that people also have ongoing appointments and abilities to engage with professionals around any experiences they may have, side effects or otherwise, with the medication. So what have we learned through this? That we have been able to leverage our health IT and to use that to support the multidisciplinary care workflows with simple kinds of prompts, visuals, using the whiteboard, and also it's, all of the recovery literature will talk about inclusion of patients in programming, in program design, and also in health IT solutions. They have, as Beth was saying earlier, this was a tool that was adapted from the acute care environment, and we felt that it would have great utility here in the mental health and addictions environment. But what we needed to do was engage our patients in that design, and that's what we did, and they gave us very valuable information on how this tool, how the form should be structured, and how to get the best engagement of patients into the process of actually using this to promote better discharge practices. And the targeted physician alerts and reminders can be very effective. There is an override function for them, but we have found that when they were alerted, then we had better rates of MedRec completion. So thank you very much.
Okay, we would like to thank our speakers for joining us today on this Davies webinar, and remind our listeners where to go find this information and other important Davies use case webinar information and information on how to apply for Davies. That information can be found posted at the HIMSS Davies Award website at hims.org/Davies. That's hims.org/Davies. Thank you for joining us today.